Hi everyone, welcome to CORNEA, welcome to Rush Batch. So today we will be starting with a new chapter, that is the breast pathology. Okay, so let us finish this chapter. I'll be doing 3 videos in breast pathology. This is your video. Second video mein I'll be discussing about the morphology of variants and I'll be talking more about the classification. And then last video I'll be discussing rate of prognostic factors and fibroadenoma and Phyllodes tumor. So in this video I'll be finishing, I'll be talking about the risk factors and as well as the pathogenesis. Is it clear? So let's dive into the topic. First of all, I want you to know the anatomy of the breast. Okay, see, in a microscopy, first of all, I'll put the photos, don't worry. Okay, so imagine this is your duct. Okay, all the ducts unite together to form what? Lactiferous duct. Is it correct? So the lactiferous duct continues as lactiferous sinus, and from the lactiferous sinus is which the milk is sucked out by the baby. This is normal. Okay. Microscopy okay. Can you see the நான் encircle பண்ணிருக்கிறதெல்லாம் உங்களால பார்க்க முடியுதா? நான் encircle பண்ணிருக்கிறதெல்லாம் தான் what I am going to call it as, it's the terminal duct lobular unit. Is it clear? That is nothing but the TDLU. Okay, what is TDLU? TDLU எல்லாமே epithelial cells. These are nothing but the luminal epithelial cells only. Is it clear? So அந்த சுத்தி இருக்கக்கூடிய பிங்கிஷா இருக்குல, அந்த பிங்கிஷ் ஏரியா தான் என்னது ஃபுல்லா ஸ்ட்ரோமா. கரெக்ட்? All these TDLU சுத்தி இருக்கக்கூடிய அந்த பிங்கிஷா இருக்குல, everything is stroma. Okay, now in the same photo, இப்போ can you see the photo? Okay, இந்த photoல dark pinkish area பாக்குறீங்களா? Okay, so அந்த TDLU ரெண்டு TDLU க்கு நடுவுல நான் மார்க் பண்ணிருக்கேன் பாருங்க. ரெண்டு TDLU க்கு நடுவுல நீங்க dark pinkish area பாக்குறீங்களா? That is nothing but your interlobular stroma. What is that called as? Interlobular stroma. Interlobular stroma is a stroma such like not only in the breast, it is anywhere in the body. எந்த இடத்துல வேணாலும் வரலாம். Like இப்போ என்னோட கை, இப்போ இது என்னோட ஹேண்ட்ல என்னோட ஸ்கின்ல இருக்கல இந்த ஸ்ட்ரோமா, this is only similar. It is also a similar type of stroma comparing this interlobular stroma in the breast. Okay, so அதாவது இந்த breastல இருக்கக்கூடிய stroma எங்க வேணாலும் இருக்கலாம், இந்த interlobular stroma. Is it clear? So எனக்கு ஸ்பெசிஃபிக்கா இல்ல, லைபோமா வரலாம், angiosarcoma, fibrosarcoma, all these are confined to this interlobular stroma. It is not a specific. Okay, now photo, in the photo lab, can you see within the TDLU there is light pinkish stroma. That light pinkish stroma is a specialized type of stroma, and what I am going to call it as the intralobular stroma. Okay, intralobular stroma. From this intralobular stroma only, what are the cancers you get? You will be seeing the Phyllodes tumor, fibroadenoma of breast. All these are tumors of the intralobular stroma. This is a benign tumor, and also some malignant tumors like invasive ductal carcinoma, invasive lobular carcinoma. All these are confined to this intralobular stroma. Just for remember now, fibroadenoma, Phyllodes, okay, and invasive ductal carcinoma, invasive lobular. You will be knowing it. What is invasive ductal? What is invasive lobular in the second part of the video in detail. Okay, so don't worry or don't confuse about it. Is it clear? Okay. So now I just want you to give the introduction. That is my motive here. Okay. For breast la pathina, breast liyum prostate liyum. Okay. You have cells. You have duct. Okay. You have a duct. Surrounding this duct, there is some cells. There are some cells. These are called as myoepithelial cells. What are these cells called as? Myoepithelial cells. So this layer is myoepithelial layer. Okay, so can I say if a cancer வந்து stroma குள்ள இத breach பண்ணிட்டு போச்சு அப்படினா, can I say it has destroyed some part of the myoepithelial layer? So that means the myoepithelial layer is not preserved in this condition when a cancer has breached into the stroma. Are you understanding the concept now? Is it clear? I hope it's clear. It's simple topic, nothing to worry about the breast. Many people are thinking that it's a tough topic. No, it's a simple topic. Learn the class properly and try to answer the questions in the next part. Okay, yeah, so we'll move on to the next. Okay, so if you just see, the breast cancer is the most common cancer in the world. You know that, right? You know that very well. Okay, breast cancer is the most common cancer in the world. Many patients you see எல்லாமே OPDs breast cancer patients தான் நீங்க பாப்பீங்க. So you must learn it thoroughly. Correct? Okay, so now let me introduce first of all breast cancer க்கு என்னெல்லாம் risk factors இருக்கு அப்படின்றதை நீங்க தெரிஞ்சுக்கணும். Okay, அதுக்கு முன்னாடி let me tell you, the breast cancer is the most common cancer of the world. இதுல பாத்தீங்கன்னா 1/3 okay, is familial. What do you mean by familial? It is hereditary. Okay, 1/3 when they break familial, or I can also call this term as syndromic. Correct? Yes. So 1/3 of the breast cancers are familial type of breast cancers, whereas the remaining cancers are another sporadic. Sporadic means what is sporadic? Sporadic means any person in the world can get the breast cancer. Is it clear? So this is the difference between familial and sporadic. Now let's go into the topic proper. What is the topic proper? Now we are going to start with the risk factors. Okay, now we are going to start with the risk factors. What are the risk factors? Risk factors na enna? In the இடத்துல நம்ம breast la படிக்கிறது relative risk. What do you mean by relative risk? What is relative risk of 1? Relative risk of 1 means no risk as compared to the general population. Relative risk of 2 means twice the risk as compared to the general population. Hey man, what do you mean? We don't understand. அப்படினு கேட்கலாம். Now you see, for example, let us take a case scenario. Okay, ஒரு person smoke பண்றான். Smoke பண்றவங்களுக்கு lung cancer வருது. Okay, let me take a group of people who smoke and group of people who do not smoke. Okay, so this is the people non-smokers, smokers. People who are smoking are at the risk of getting lung cancer. What we do is we'll compare. Okay, so here I'll just put a group of people. நான் வந்து பார்க்குறேன் இந்த மாதிரி. Okay, இங்கே ஸ்மோக் பண்ணுறவங்களுக்கு கேன்சர் வந்து இங்கே வரல. ஸோ நான் ரிலேட்டிவ் ரிஸ்க் ஆஃப் 2 சொன்னேன்னா ஸ்மோக் பண்ணுறவங்களுக்கு twice the risk as compared to non-smokers. Are you understanding the point? So this is what is meant by the term relative risk. So now we have to see relative risk of more than 4. Okay, that is 4 times the population, 4 times the risk compared to the general population. Then 2 to 4, then 1.1 to 2. Is it clear? We have to see, and the university will ask this for 5 marks. And risk factors of breast cancer and prognostic factors, both they will put together as a 6-mark question or a 5-mark question based upon the university. Okay, so you should be thorough with the risk factors and the prognostic factors. Now the prognostic factors will be done in part 3 video, and now I'll be finishing the risk factors. Okay, I'll just write it. Okay, I'll just show the photo, and you will be able to understand. Okay, so let's start. I hope I have put the photo. Okay, so now can you see the photo? Yes. So first of all, what is written there? Relative risk of more than 4. That means 4 times the risk compared to the general population. Okay, fine. What is the risk? Tell me. See, first female gender. Female irukkiradhu or risk factor. Gender, that is female gender, and age itself, age for females itself is a risk factor, the second risk factor. Then what is the third risk factor? The third risk factor is the germline mutation of high penetrance. There is some mutation. What mutation do you think so? It can be the BRCA1 and BRCA2. Okay, what mutation it can be? BRCA1 and BRCA2 mutation. We will see that in detail. Okay, in a high penetrance mutation, BRCA1, BRCA2, we have something. I'll be discussing about it in detail, so don't worry. Strong family history. Strong family history, more than 1 first degree relative. That is mom, okay, the sister, any of these siblings. So like that, they can have that is more than 1 first degree relative cancer. We can suspect of a breast cancer. Okay, next, personal history of breast cancer. Okay, so there is something called as DCIS. What is DCIS? Ductal carcinoma in situ. So ஏற்கனவே உங்களுக்கு DCIS இருக்கு. It can progress to a malignant cancer. Is it clear? So that is what we will be discussing about DCIS in the next video, so don't worry. Next, high breast density. Why are you saying people having a bigger breast will have a chance of breast cancer? Do you say that? No, not like that. For example, let us have 2 breasts. Okay, this is a smaller breast and this is a larger breast. Smaller breast is having a thick, more and more fat, and larger breast is having another less fat. That means this breast is loose and this breast is thick. Okay, so which do you think is having a high chance of cancer? This one, right? Why? Because fat will convert everything to estrogen. With the help of estrogen, the cells will proliferate, right? So that it can lead to increased risk of cancer, right? So if, for example, if a patient presents to the OPD, she is a female with age 40 years, okay, then having high breast density and personal history of DCIS, just try to suspect it of a cancer. Is it clear? Try to suspect a breast cancer and try to just suspect. Okay, so and also a strong family history. All this is suggestive of the another relative risk of 4 breast cancer. That is high risk of chance of breast cancer. Is it clear? Okay, so now let me discuss briefly about the mutation. Okay, that is the germline mutation of high penetrance. What is this germline mutation of high penetrance? What do you think so? See, germline mutation of high penetrance means I am just talking about the BRCA1 and BRCA2. Okay, BRCA1 and BRCA2. Most of the 55% of the familial cancers. The BRCA1 mutation, gene mutation. Okay, so BRCA1, BRCA2. In the genes. See, all this BRCA1, BRCA2 and FAN. All these are part of a FAN complex. There is something called as FAN complex. Okay, this is the BRCA1 and BRCA2 in the gene. This is in the FAN complex, chromosomal repair. Okay, when this FAN is lost or BRCA1 or BRCA2 gene is mutated, stem cell level there is some problem created. There is aplastic anemia. So that you can think of in the FAN if the FAN is destroyed. So this complex is mainly involved in chromosomal repair. Also, you should remember that this gene is present in chromosome 17. Is it clear? Just for your MCQ purposes. Okay. Patient BRCA1 mutation cancer breast breast metastasis. When a patient comes with complaints of breast cancer plus and she has tumors of ovary and it is also involving the fallopian tube, you can suspect of a BRCA1 mutation. If it is in males, means breast plus prostate. The similar way BRCA2, but most common cancer of another, that is men not common. Men cancer, men do have breast, okay, but it is non-functional. And men cancer breast cancer the gene it is most obviously the BRCA2. Okay, BRCA2 mutation men another breast cancer cause chances. So clear. Now coming to the next. Any other genes can cause this mutation other from this one? Any other? Yes, we have, that is P53. Okay, P53 gene also can cause sarcomas, leukemia along with the breast cancer. See, sarcoma, leukemia, mesenchymal tumor, okay, and also blood tumor. See, yes or no? So P53 gene mutate, there are more and more chances, right? Also, can I say if there is a mutation, what is this P53 mutate? What is the gene? What is the name of the syndrome? Leigh-Ferroni syndrome. Okay, P10 mutate Cowden syndrome. Okay, all these are belonging to the mutations in the germline, that is germline mutation of high penetrance. Okay, this is CDH mutation. Do you know what is CDH mutation? E-cadherin loss. I will be discussing in the next video in detail. It will cause invasive lobular carcinoma, right? This is the diffuse gastric carcinoma of the stomach cause. That means it is also having a chance of involving the breast, ovary, okay, in a diffuse gastric carcinoma. Okay, you will be discussing, everything will be done in neoplasia, don't worry. That's why I am not stressing much. I am just mentioning the genes over here. And also STK11 mutation, gene mutation causes Peutz-Jeghers syndrome. Okay, just remember Peutz-Jeghers syndrome. So these are the other genes associated with the germline mutation of high penetrance. Okay, so next let us move on to the next relative risk factors. Okay, that is 2.1 to 4. Okay, yeah. Okay, let us continue. Now the relative risk of 2 to 4. Can you see the photo? Relative risk of 2 to 4. Yes, germline mutation of moderate penetrance, you can see, and also you can see the high dose radiation to chest. What do you mean by high dose radiation to chest? If chemotherapy or lymphoma, thymoma, they will give the chemotherapy, right? If chemotherapy, is it possible to shield the chest? Not possible, right? The chest will be exposed to the radiation, so that might lead to a cancer. So these are all moderate risk. Okay, that means relative risk of 2 to 4. Next, familial history, that is first degree. For example, first degree, what is the first degree familial history you think of? The mom or the sibling. Okay, so if they are having a risk of breast cancer, that means it's a relative risk of 2.2. That is more than 1 first degree means it's more than 4. 2.1 to 4 lies for the familial history of 1 first degree relative. Is it clear? Now coming to the relative risk of 2 to 4. Okay, so 2 to 4 the germline mutation of moderate penetrance. What are the genes involved? Remember 2 genes, ATM and check gene. What is ATM? Ataxia telangiectasia mutation. You have studied it in biochemistry. Okay, once you just see ATM gene and check gene. Okay, check gene. So this check gene is mainly involved in thyroid, renal, okay, and along with the thyroid, renal and colon. Okay, 3 cancers: thyroid, renal and colon cancers. Is it clear? This is check one is involved by the. Okay, so this is all about this relative risk of 2 to 4. What is C in relative risk of 1 to 2? Can you see? I can see the early menarche, late menopause, late first pregnancy. Okay, so can I find something common in all these things? All have early exposure, that is increased exposure of estrogen. Can you see that? Early menarche estrogen adhigama secrete agum, right? Late menopause also, late first pregnancy also, because pregnancy la yaar secrete avra? Commentate down. Nulliparity. What is nulliparity? Nulliparity means the woman hasn't yet been pregnant, right? So then there is no children. So at that time she could have more and more estrogen. Absence of feeding, okay, because lactation time estrogen secrete agad, right? Next, exogenous hormone therapy. Post-menopausal obesity itself is a risk factor. Physically inactive, high alcohol consumption, all these things will increases the risk of estrogen exposure. So what is this role of estrogen? Can I say estrogen will be involved in another cell division and cell proliferation? So cell division, cell proliferation, and that can lead to breast cancers. Is it clear? This is all about the relative risk of 2 to 4 and 1 to 2. Okay, so now the next topic which we are going to deal with is about the pathogenesis, the molecular pathogenesis lying behind the breast cancer. The molecular basis behind the molecular pathogenesis behind the breast cancer will do now. So now it's a normal breast parenchyma. This normal breast parenchyma is going to undergo a BRCA1 gene mutation. Okay, now what is BRCA1 gene mutation? Now last is explain panna, so now I will explain. BRCA1 gene mutation mostly triple negative cancers la mutate aayirukkum. BRCA2 gene mutation normal in the mutate aayirukkum, that is estrogen receptor positive breast cancer, that is ER positive breast cancer. Just remember this. Okay, so now there is a BRCA1 gene mutation. Now I want to explain one concept before this. There are two alleles, correct or not? First allele வந்து இப்போ வந்து birth முன்னாடி mutate ஆகுது, and the person lifelong second allele mutate ஆகல. Will he be having a risk of cancer? No cancer risk. Okay, இப்போ ரெண்டு allele இருக்கு. First வந்து birthல mutate ஆயிடுச்சு, ரெண்டுமே birthல mutate ஆயிட்டா கரு கழிஞ்சிரும், கரெக்ட் ஆர் நாட்? ஸோ இப்போ ஒரு allele வந்து birthல mutate ஆயிடுச்சு, later stages of lifeல the second allele is getting mutated. Can I say he has an increased risk of cancer? This second mutation can be due to many other gene mutation. Are you understanding? So this is what is Knudsen say. You would have learned everything in the neoplasia only. Okay, it's okay. Now let us go into the concepts. Okay, fine. So now there is a BRCA1 mutation. Okay, it's a first hit. Now there is genetic TP53 loss in this patient. Okay, inge vandu TP53 loss ஆயிடுச்சு. Now after that, is there a chance that second hit நடக்கிறதுக்கான chance இருக்குல? Yes. So that is what BRCA1 gene வந்து இப்போ நடக்கிற mutation வந்து second hit mutation. இப்போ இது நடக்கிறனால what is going to happen? Now this will progress to ductal carcinoma in situ. Ductal carcinoma in situ na ஒண்ணும் இல்ல, this is the duct, you know. Okay, so in the ductல வந்து there is a clonal proliferation of cells. There is a clonal proliferation of cells inside within this terminal duct lobular unit, and அது வந்து உள்ளுக்குள்ளே தான் இருக்கு. அது வெளியே இன்வேட் பண்ணி போச்சுனா நீங்க இது ஒரு டேர்ம் கொடுப்பீங்க. அது உள்ளுக்குள்ளே இருக்கிற வரைக்கும் you call it as DCIS only, and this DCIS will progress to what type of cancers? Triple negative cancer. You know, right? Because it's a BRCA1 gene mutation. Okay, it's very worst prognosis. Okay, triple negative breast cancers. Is it clear? So triple negative breast cancer வந்து இது பண்ண முடியுமா? ஈஸியா டயக்னோஸ் பண்ண முடியுமா? இது வந்து என்னெல்லாம் நெகட்டிவ், you will be learning it in the next video. It's ER negative, PR negative, ER negative, PR negative, HER2 negative, everything, all the gene அது எல்லாமே நெகட்டிவ் இங்க, right? So then triple negative cancers are worst prognosis. ஏன்னா நீங்க ஒண்ணுமே தெரியல எந்த இதுனே, so it's a worst prognosis. இப்போ ER பாசிட்டிவ்னா estrogen receptor பாசிட்டிவா இருக்கு, so I can give a therapy. என்ன தெரப்பி கொடுக்கலாம்? You would have learned it in pharmacology, endocrine, SERMs கொடுக்கலாமா, tamoxifen, raloxifene, right? இப்போ HER2 பாசிட்டிவ்னா கூட நான் trastuzumabன்ற ட்ரக் கொடுக்கலாம், பட் இங்க I can't do anything, right? You see, triple negative cancer na what is the only way? It's a chemotherapy. Is it clear? Next, coming to the normal breast parenchyma. Now listen, there is a BRCA2 mutation. What type of mutation is there? BRCA2 mutation, and along with this BRCA2 mutation there is a loss of chromosome 1q and 16p. Okay, in the chromosomes loss aayirukku. Now what you see is a flat epithelial atypia. அதாவது இது dysplastic epithelium தான் இருக்கு. It's atypical that means it's dysplastic. Atypical means here dysplastic. What is that? Flat epithelial ATPR. Okay, that means epitheliumக்குள்ள தான் வந்து அந்த pleomorphisms எல்லாம் மாட்டிட்டு இருக்கு. அது வெளியே எங்கேயும் breach பண்ணிட்டு போல. So flat epithelial ATPR. Is it clear? So now after this what is going to happen? See, the next again what is happening means now there is a mutation in the PIK3CA. Okay, இதுல ஒரு mutation வந்து again it is going to become DCIS, but it's a BRCA2. BRCA2 என்ன இதுல வரும்? It's a estrogen receptor positive, right? So ER positive breast cancer. Is it clear? Is it a good prognosis? These are luminal type of cancers. ER positive, I can treat it. Yeah, it's a good prognosis. Okay, the last one, let us see. Now next one, if you just see, there is a germline TP53 loss. By germline, there is a germline TP53 loss. Okay, now in the TP53 loss there is something called as HER2/neu, right? This HER2/neu is a part of ERB2 receptor family. That means these are epidermal growth factor receptors. இது இங்க என்ன நடக்க போகுது அப்படினு பார்த்தீங்கன்னா amplify ஆக போகுது. Okay, growth factor வந்து amplify ஆச்சுனா what is going to happen? பயங்கரமா வந்து எக்கச்சக்கமா அது பாட்டுக்கு டிவைட் ஆகுது growth factors. It will lead to cancers, right? So here it will lead to HER2/neu positive breast cancer. Okay, is it clear? So this is the molecular pathogenesis behind the breast cancer. I'll put the photo of Robbins. Can you see the photo? Yeah, there's a BRCA1 mutation and leading to triple negative cancer, BRCA2 mutation leading to ER positive breast cancer, and the final one TP53 loss leading to HER2/neu breast cancers, right? So this is the molecular pathogenesis behind the breast cancer. The last and final touch, with this I'll close the video. Please, first of all, how will you diagnose breast cancer? That is self-breast examination is the best way. Sometimes patients may find with help of self-breast examination itself. Okay, அதுக்கப்புறம் they can go to a doctor. ஒருவேளை அவங்களுக்கு பண்ணலனா, so that's why creating awareness is very important. How to do create awareness? என்னன்னா ரோடா போய் இது பண்ண சொல்றீங்களா? No, just teach your mom. Okay, after completion of this, watch the self-breast examination, whether you are boy or girl, don't care about it. Okay, watch the self-breast examination, teach your mom. Okay, so that அவங்க இன்னும் 10 பேருக்கு சொன்னாங்கன்னா because என் பையன் சொன்னாங்க என் பொண்ணு சொன்னா அப்படின்னு confirm that talk will come, right? That talk will arise. So definitely ஏன்னா content இல்லைன்னா they would come to some point of time they would come to a content, right? So just watch the self-breast examination and learn. As a doctor you should have known self-breast examination by now. Okay, so watch after this video, and for exam point of view directly நீங்க diagnose பண்ணலாம் அப்படின்னு கேட்டாங்கன்னா you can talk about the mammogram, right? Mammogram will pick up the calcifications in the breast, right? It's just like a X-ray or breast X-ray mammogram. Is it clear? So with this I will wind off the video. Okay, the next class will start with the the morphological variants and the classification of breast cancer. How just I'll be talking about the positive, negative, is ER negative. That I'll talk about it. Okay, thank you. Good night.